Hey, Dr. C here with you. So, wanted to give a quick update. I think that what we now know about the trends and the expectations has shifted what the top priorities are and what our expectations should be moving forward. Quick summary for what's ahead. It appears that we'll need to have the vast majority of Americans develop this infection before it's going to slow down. So you've got a good chance of catching it. We've talked a lot about your ways to resist it. I want to talk in this one about who's at risk for complications and what you can do to really avoid those complications. So let me go into a bit more depth on where all this came from and what this new perspective is based on. You know, I've just been spending a fair amount of time each day reading some of the latest medical literature that comes out, and it's happening so fast. It's a minute-to-minute basis that new research emerges, and it might shift our perspective. And seeing some of the newest papers, I started thinking about just what are the real implications from this. So the first thought is, you know, what are we looking at for the peak? And the peak of activity we're expected to see about April 14th, April 15th. You know, odd thing, that was our old tax day, not our current tax day. And the peak doesn't mean that on April 16th it'll be gone. It means that the number of new cases, the number of new deaths on April 16th for the nation will likely be lower than it was on April 15th. But it doesn't mean none. It's going to be quite a while before it ramps down to where it's lower. And we'll have some lapses afterward. And that'll be quite different from region to region. But that's the projection for the peak. And the thought is, well, what's really going to slow that down and what's really going to change that? So the considerations have been antivirals, vaccines, and herd immunity. And I'll just touch on each of those and what we know now. So antivirals, that's the medications that can kill viruses. You can think of those as antibiotics for viruses. They're things that would just make them not properly replicate. Now, what we know is that antibiotics are hard to make, and there's no big cost incentives to make them. So people don't take them all the time, every day for the rest of their lives. If they need them, they'll take a week or a course of them here or there, but not much and not long. So they're medications that have not had much support or much active research. And within antibiotics, you can think of antivirals to where these same complications are even worse. Now, we've had a lot of research, a lot of development on HIV. That's been great for helping HIV, and it's also helped to expand our understanding of how viruses respond. However, it's shown us that they're not easy to treat. They're even harder to treat than bacteria are. So the mean time frame to get a new medication on the market for an antiviral is about 6.4 years for the current time frame. Now, of course, we could be more aggressive, we could speed that up, but we're talking about incremental gains. 6.4 years cannot be turned into 3 months. Maybe that can be turned into 5 years. That would be a pretty big win, but that won't happen in 2020. There will not be new antivirals in 2020. Now, the existing medications that are in use, we may learn more about those. That will take time. The biggest drawback is the hydrochloroquine and chloroquine and azithromycin. They're being talked about individually and in combinations. Well, they have cardiac side effects. That's important unto itself, but it's especially relevant because one of the ways in which COVID-19 causes mortality is by causing cardiomyopathy, by causing enlargement of the heart, and also myocarditis, so inflammation of the heart lining. These are both ways that it can be harmful. And when medication side effects overlap with that, it makes the medications less relevant. You know, they might have some benefit overall, but if they can't help those who are at risk and they could overlap with the complications of the infection, that makes them less useful. So medications may be a very helpful thing, but probably not this year, probably not in the short term. Next up, we think about vaccines and what's the latest data about this. So we're talking about floppy viruses, and these are ones that are just really hard to make safe vaccines for. Some of the reasons are the nature of their protein coats, also the number of strains that can come about, and the difficulty is that you want to get enough of the antigenic material. That's the surface coats that identify the virus to your immune system. You want enough of that to get immunity that's retained, but you don't want so much of that that it makes you sick. And that's the trick with vaccinations, is always, how do we get enough to give you immunity, but not give you so much that you might as well have the same infection? And that has been largely achieved with many vaccinations. But for this category of viruses, it's really tough to do. So the thought is you could use a certain number of surface coats markers, and that could give you some level of passive immunity, but that may not last with real-world exposure. So this will be a little while, and most experts are now saying this is something that's more a matter of years. Most aggressive timeframes are probably 18 to 36 months, so not something that'll happen this year either. And truth be told, there's a little more detail to that. There's a matter of having a vaccine available and then having a vaccine that's safe and consistently effective available. And that's pretty important. It's got to work and it's got to be safe. And that could happen, but again, that'll make it take longer than this 12-month time frame that some have optimistically talked about. Then we think about herd immunity. So herd as in not like herd, but as in like a herd of cows. Not have you ever heard of cows, but have you seen a herd of cows, like a bunch of them. So yeah, H-E-R-D. And basically if enough people have had it, they are resistant to it. And all data does seem that if you have had it, there's a certain time frame. We're not sure exactly how long, but there's a time frame after which you're no longer contagious and you've got some probably lasting immunity. And in the case of measles, for example, if 95% of the population has an immunity to it, either from having it or being successfully vaccinated, it won't really get a chance to take root in that population. There's just not enough susceptible people to pass it around well. So even if some get it in isolated cases, it wouldn't really make a big movement throughout the population. And the thought is with COVID-19, that would require somewhere like 60 to 70% herd immunity, that much exposure to where overall the virus can't just take off like wildfire any longer. And well, the thought is, how long will that take? So that's likely to occur in 10 to 12 months. So that's worth underscoring and just thinking through. So 10 to 12 months, 2020, I want to say 19 still for years. I'm dating myself, but yeah. By the time 2020 is out, we think that 60 to 70% of Americans will have had coronavirus. So that means a lot of people will be sick from that. It does mean that we may be able to get some passive immunity. And we'll think through these implications, but let's just play out these numbers a little bit. So there's about 327 million people living in America. And what we've seen, a strong trend, is that about 20% of people that get COVID-19 do require hospitalization. They get really sick from that. So, and we're also saying that if we need about 60% to get exposed for herd immunity, so 60%, that's 196 million, so just about 200 million. And if 20% of those who are exposed will end up being hospitalized, that ends up being about 39 million people. Then we think through the mortality rate. So how will that be affected? And we've had data from China, and the mortality rates from China and Korea have been in the 0.4%, 0.1% range. They're thinking it's somewhere in there. But many experts think that it'll be quite different in the United States. So the mortality is highly related to certain risk factors. We think about age, blood pressure, kidney function, smoking status, obesity as some of the big ones relevant in the Chinese population. Now, most of those who died were Chinese men over the age of 70. It turns out that Chinese men over the age of 70, almost all of them smoke. 70% or more are smokers, whereas Chinese women in the same age group, less than 9% of them smoke. So was it really just the age, or was it more so the smoking status? In the United States, we've got less total smokers. Now, on the other hand, there was a very low rate of more so young to middle age adult death in China. However, there was a higher rate amongst those who were obese, who did have obesity. And we know that the percentages of that in the population is much lower than it is in the United States. And so we think these things through for what are the main risk factors, how do those risk factors show up in the population in China and their demographics, how do those risk factors show up in the United States? When you run the numbers on that, we're seeing estimates more like about 1.5% mortality. We have a lot more people with many of those risk factors. So in that case, we're talking about possibly 2.9 million deaths over the course of this coming year. We hear a lot about 100,000 being a great goal as far as 100,000 deaths, or 200,000 being another window of that. That's not for the year. That's for the current surge. That's like for the next few weeks. So the number for the year is probably more like in the 2 to 3 million range. So herd immunity and 60 to 70% exposure. So what does that mean? What does that mean for real risk? What's tangible with that? Take a coin toss. Let's say that heads you win, tails you lose, and tails is getting COVID. So if you toss a coin, did you get tails? Nope. Toss it again. Did you get tails? 2 coin tosses. The odds of getting tails on 2 coin tosses are pretty much your odds of developing COVID. So then the thought is it better to get it over with? Is it better to get that earlier than later? And I've thought through a lot of models and arguments that way. Some have actually argued that there may be an advantage to getting it earlier because there are a lot of supply chain issues that have not yet fully manifested in healthcare. And it's not even just a matter of masks or ventilators. It's also a matter of just common medications used in ICU care, antibiotics, epinephrine, things along those lines. These are things that are thought to hit a shortage in the coming days and weeks. And it's possible that those who get this later on and get complications may just have less access to some of those needs due to supply chain issues. But the overall net effect is that getting it later, having it be more delayed for many, is definitely of net benefit for society. And if you're getting it later, it is also possible that you may be so late in the game that herd immunity may be reached before you are exposed. So I would strongly, strongly argue against any of the points of trying to get early exposure. This is not an idea of having a chickenpox party, not by any means. So yeah, the best first line strategy is hoping for herd immunity and hoping that this will occur before you've been exposed. So that's the goal. So keep doing all the good things you're doing. We're going to be doing them for a while. I'm glad to hear the term physical isolation replace the word for social isolation, because that's a healthier concept. We don't want to socially isolate. We want to socially connect. But we do want to physically isolate. That is important. And it's so critical to keep your body moving, to get some exposure to the outdoors when you can. That does take some thought and planning. You don't want to go to the big national parks or the popular trailheads or whatnot. But yeah, get outside, do physical distancing outdoors as you're being active, and have your shelter in-stay group that you're with. Now, of course, if you're one to where you're at a critical sector in society and you're in the workforce that's needed, can't do that as much. But otherwise, as much as you can, avoid, wash, be cautious with your packages, all these things, that's your first line. And having said that, let's just be real. There will still be many who do all the best things and still will get sick. So then the thought is, well, if you are doing some version of shelter and stay, can you solo quarantine? I've got a really dear friend, a good man who's an ER doctor, and they have a guest home, their house, which is not physically attached to their house, and he comes home and for the last 3 weeks, he's not physically seeing his family. He's staying in the guest quarters and he's taking his meals there and staying isolated. I imagine there are many people to where if they were sick or if they were suspecting exposure, they just wouldn't have the means or the capacity to do that. Maybe they're a necessary caregiver. Maybe there's just not the physical space for them to be completely removed. Kieran talked to a couple in New York where they decided to give up on the idea because they're sharing a kitchen, they're sharing a bathroom, and they just didn't really have the means to have each other completely quarantined from apart. So that's tough. I'm guessing that in most cases, if you're exposed or if you get it, you will expose those you are doing shelter with, and that's your family. So going into this then, we start to think a lot about, okay, so if I get this, if I share this with my family, what can I do between now and then to make sure that we don't get complications, that we do well from this? So let's shift the discussion there and talk about what we know about the complications. Some of these are things that we can address and change the risks. Some of them are things that we can't do as much with. So some of the big ones are going to be renal disease. We're going to think about it and about how diagnosed it is and how prevalent it is. That's the first one I'll discuss. And I'm talking about it first because there's not as much to do about it separately. It does happen. This probably does affect 15% of the adult population. We think 80 to 90% of those with chronic kidney disease have not been properly diagnosed. If you do have it or you are at risk for it, the main thing that you can do to help with that are to improve your blood sugar and improve your blood pressure. And those are things we'll come back to because they are separate risk factors. Then we think about age. Well, that's obviously not one we can change, and that's also one in which that's been skewed because of how we have more risks in the youth than the Chinese population does because of our obesity rates. And let's talk about that. So how prevalent is that? Well, as of 2019, it varies a lot from state to state. We've got some states that are in the mid to upper 20s, some states that are in the mid 60s for percent obesity in the adult population. Overall, American adults, it's somewhere around 40%. And I've talked before about how, what does this mean? What is this definition, obesity? It's a disease. It's not a label for a person. It's a disease process. But how do we define that, and how should we define that? And I do believe that as we see more data, what we've seen in the case of diabetes and other risks from overweight or obesity, is that it's not just height to weight. It's more so the growth of fat around and in the organs. And that's best translated by height to waist circumference. However, as we stand now, our data that we have about COVID complications is based upon just height to weight, and specifically based upon body mass index. So I'm including a common chart in this blog. Take a peek at that and look at where you fall on the body mass index scale. We define obesity as a body mass index of 30 or greater, and then overweight as 25 to 30. We now have more detailed versions of mild and moderate and severe obesity. Those replaced some older terms that were used. But do know where you sit on that continuum, and we'll talk more about the relevance of that and some action steps for that. And as we talk about it, it's something that we want to help to mitigate and reverse the extent to which we can, but also we want to prevent it, because this whole shelter and stay thing process, I've heard many talk about, we're comfort eating. And that's completely normal. When we're stressed out and frazzled, we comfort eat. We're less physically active. We're being put more at risk. Okay, so other risk factor would be chronic pulmonary disease. And prevalence of this, we've got about 16 million Americans with some mixture of chronic obstructive pulmonary disease, chronic bronchitis, emphysema. So what can you do about that? What can you do to treat it if you have it, prevent it if you don't? Well, biggest single factor by far is not smoking, quitting smoking. Vaping is popular now and getting more common. The best thing we know is that it's certainly not safer than smoking cigarettes. It may even be more harmful. So yes, smoking, vaping would all be big risk factors. Now that we go way, way, way down, then we think about just indoor air quality being relevant, and also exercise levels, activity levels, and overall pulmonary reserve, how much lung reserve you've got because of your fitness, really. So that's the biggest part of that one. Next big risk is going to be blood pressure, hypertension. And we define that as blood pressure levels consistently greater than 130/80. And this is crazy, crazy prevalent. Per age, per demographic, this can be a third or this can be the majority of Americans. There's also differences per ethnicity that can be quite striking. So this is a lot of people. And this is a big direct risk factor for complications by itself, but it's also a risk factor for greater tendencies towards kidney disease, which is a secondary factor as well. So blood pressure is huge, and we'll talk about thoughts about addressing that as well. Next up is diabetes, and this is quite relevant. We've got type 1, which is more so autoimmune, generally younger people. And that's significant. It does seem that that COVID complications are more prevalent in the young with type 1 diabetes, but they're also quite prevalent in those who are just adults that have type 2 diabetes. And we define diabetes based upon blood sugar levels. So we look at your short-term blood sugar, your morning fasting glucose, and we look at a 3-month approximation of glucose, your hemoglobin A1C. Those who are at risk are those who have a morning fasting glucose somewhere above 89 is one of our current best estimates, and an A1C above 5.4. Those who just out and out have diabetes, they've got a fasting glucose above 125 on multiple occasions, so 126 or greater, or they've got an A1C greater than 6.4. And that's pretty common stuff. This is prevalent now. If we combine those at risk for diabetes along with those who have diabetes, we're looking at the majority of Americans. One of the papers I saw a couple of years ago, it was just over 50%. So this is now the majority of people who have some risks that way. And I'll come back to the idea of walking and movement and steps, but one of the biggest predictors of diabetes in a population is how much the population walks or bicycles as a means for transportation. So not just for fun, but do you walk to work? Do you ride your bike to school? Do you walk to the store? America doesn't do that. We just don't really do that. People don't, unless they have fewer choices, generally people don't use those ways to get around. I just talked to one of my coworkers and he said, yeah, we walk to the car. We walk to the car and take the car to where we're going. And that's just how we live our lives. So that's a big relevant risk factor. And I think that that's something that is only going to be worse right now. I'm sure that number of people who are walking to school is not higher than it was in January. It's people aren't physically going to school or walking to work, riding bike to work. We're not doing that. So those things are only more relevant. So given all that, let's think through the implications in our big action steps. It's likely that you will get COVID. The odds are that you will. Now, I hope you won't. And if you end up avoiding it and we reach a point of herd immunity before you get it, that's awesome. That's totally cool. I would love for that to happen. So let's hope for that, but let's also have contingencies in place in case that does not happen. So the contingencies, again, this is about you, but I want you to think this is just as much about those that you are physically with. I know many people to where they were traveling, they were with some friends, they weren't so much at home, but they're stuck there because that's how they're being sheltered and that's where they're being kept for a period of time. So wherever you are, whoever you're with, it's probably your family, but whoever you're with, think through these risks for them as well. And as much as you and they can do together collectively to mitigate the risk for complications, the better. And here's the thing. The extent to which you lower your blood sugar, your blood pressure, you can improve upon your body mass index, that's a win. And if it turns out that we are having a conversation a year from now and COVID is a memory and barely relevant, I don't think that'll be the case. I wish it would. But if we were having this discussion now, the biggest risks would be the body mass index, the blood pressure, the blood sugar. Those are the main things that cause non-communicable disease and early preventable death. So it's only a win if you improve upon those. If not for COVID, for everything else. And again, for you and for those around you. Now here's the other useful thought. Those things, it's funny because we call them non-communicable because you don't so much spread high blood pressure, but in ways you kind of do. And they've shown that your social spheres, your social circles, may be as predictive of your risk for those complications as your habits are. So in some ways, we are what we do, but also we are who we are with. So what better opportunity than right now to make a big shift in these risk factors and do it with those who you're stuck in the house with anyway. So yeah, you need to because somebody in the house is probably going to get sick. Those odds are pretty good. And if that happens, there's a good chance it'll spread to others in the house. So let's think through how to really mitigate those risks. And in general, the idea is You want to get fit. You want to move, you want to get fit, and you want to become lean. And lean is healthy for you. And those things, improving your body weight, those same steps, can improve body weight, blood pressure, either diabetes or diabetes risk, your health in terms of your pulmonary function, your lungs, your overall immune response, your chronic stress state, your sleep. Those things will help you across the board in all those ways. So what's the best way to do that? What's the best way to shift your blood pressure, your blood sugar, your load of visceral body fat? Well, that was the question that I really had top of mind when I wrote the last book, The Metabolism Reset Diet. And the idea of just eating less or just moving more or cutting a lot of foods out, if anything has worked already, that's awesome. I'm glad that it did. And I begrudge nothing. Whatever you did that worked for you, if you dropped a lot of body weight and kept that off, totally cool. It was worth it. But for a lot of people, it doesn't work that easy. Things either don't work at all, or if they do, they relapse quickly. So I pulled through all the medical literature and thought about it and realized that, some big variables were you need adequate protein. So if you're lowering your food intake and you don't compensate by still getting a good maintenance amount of protein, you're going to lose your lean body mass. And that's going to set you up for yo-yo dieting. You're going to regain whatever it is you lost, probably, and then some. Also, if your protein intake goes down too much, your appetite's going to get out of control. And, by force of will, you might lower your food or adjust that, but it's like holding your breath. You can't keep that down. It's going to come back with a vengeance. So that's the other perk about including the protein. Then I thought a lot about how long do you do it for? How long do you adjust your food intake? And I saw a lot of data saying that somewhere around 5-6 weeks, when you do it that long or longer, your body has a big shift. Your metabolism really shifts in a bad way. You slow it and you suppress it and you don't burn fuel as effectively. So this is not a way you want to live your life. You don't want to always be consuming less food than your body needs. However, up to about 4 weeks, you don't really see that metabolic harm. So my thought is to do that at 4-week intervals. And what I would suggest is that if your body mass index is at a good place right now, it can be a nice thing to do it once a year as just general benefit to your liver health and general metabolism. If your body mass index is not where you want it right now, do this once per quarter. Do a month per quarter in which you are in an active reset process and you're consuming your protein. I thought too a lot about how your liver can make weight loss harder. And so you want to include nutrients that support your liver. Big variety of fruits and vegetables, lean proteins again, resistant starch is great for that, intact whole grains, beans and legumes. There are some food categories that are especially useful. So we have the APACA vegetables, things like carrots, parsley, celery, turnips. They're all really good and they have unique effects upon liver function. Then we've got the cruciferous veggies, the broccoli, the cauliflower. So you want to include lots and lots of food diversity, lots of good plant foods, lean protein. And then the thought is, well, what about, what's the easiest way? What are the simplest rules? And what are the things that have the best evidence for making it effective to eat less and not go crazy? And there's a lot of good data around the strategies of meal replacement. So not so much 50 food rules, but just do an easy pre-made liquid meal for 2 of your meals and then 1 good rational meal for the 3rd. So you do a shake for breakfast and lunch, have a good dinner. And I did some work to show that between those times, there was really no loss by including vegetables as a snack. And there's probably a lot to gain from that. So I've talked about unlimited foods. You can make up good dishes, like you can do some really good, Kieran's got an awesome eggplant ratatouille recipe. You can munch on carrots. You've got a lot of ways to help between the meals if you need that. So that's the basic idea between the metabolism reset diet. And that's the best approach that I've found for helping people not so much just weight, but improve their waist and improve their BMI and have that stay off and have that stay off easily. So if your BMI is not where you'd want it to be, I would encourage that. And all these things fell into place for me, honestly, just this morning, just thinking through the latest research, thinking through the implications. Wow, we probably will get sick. How do we avoid these complications from that? Bang, these are the same complications. The obesity, the blood pressure, the kidney function. These are the main complications that we can reverse by improving our metabolism, the diabetes tendencies. So this is the best approach. And then the thought too is, if you're not on an active reset, what can you do for maintenance? The biggest single thing I would encourage, I talked a lot in the book about just general maintenance diet ideas. And yeah, plenty of food categories, still adequate protein for general health, keeping your satiety up, but then movement. So this is so easy to not get right now, but you need your movement. Now, during the reset, I'll talk about ways that you still should move. You don't want to train hard, and that probably won't be difficult right now. It's a difficult time to train hard, but it's easy not to. On the other hand, it's far too easy to get almost no movement. So during the maintenance phases, I'd love for you to get at least 12,500 steps per day. Grab yourself a pedometer. We'll look at some options to send some out if we can, but your phones can often do that. A lot of watches can, but find some way to count your steps. Make 12,500 your target. Now, that sounds like a big number. We've heard 10,000 quite a bit in the past. And yeah, this is our best current data around those ideas. And what I've learned too is that this is not that big of an age difference, that step target. So if you're above 6 years of age, that's probably a good target for you. You know, kids, their steps are not as big, so they won't cover as much distance as we adults do. But think about how much more, how rarely they will sit still for long periods of time. You know, how much they fidget and move around. We call this the non-exercise active thermogenesis, or NEAT. And kids do more of that, but altogether they should be getting about the same step counts. So you can easily play games with the family, with those of you around, you know, do a home step challenge, but 12,500 is a real good target to have. So if you've got the means to walk outside, please do. Do respect social distancing, mandatory. Kira and I were out the other day, and I take it so far as to even try to be upwind. So if there's a bit of a breeze, yeah, separate yourself and stay upwind so the wind blows away from you, not towards you from the other group. So yeah, social distance, get outside. If you can't get outside, perhaps you've got a treadmill, maybe not. There are some easy home stair-stepper devices, which are not like the big gym machines, but just little devices you can just step on in place. And honestly, you can do that without much equipment at all. You know, you've probably got a small stool or a small stepping platform you can use. Even just, I heard someone say that they've got a staircase and just the first and second stair in the staircase. Grab something you can step up and down, which could be even just like 8 or 10 inches. Put that wherever you tend to watch Netflix and make it a game to where try to be stepping for half the time you're watching television. And if it's a small step and you're just going up and down slowly, it doesn't have to be major exertion, but you'll count your steps. It'll still log and it'll still track and it'll still go up. So to do a reset, after thinking this all through, readjusted our calendar, and I want to do a big one on April 13th. I'd love for you to join me. And this is going to be a free reset challenge. There's nothing, we're not selling anything on this. This is just advice, this is guidance on how to do the whole metabolism reset. If you've got the book, it's wonderful, it'll help you a lot. If you don't, we'll still give you what you need to get going on that. And we're going to help it make sense to where it's more applicable to our current situation. You know, we're going to make sure that the recipes are ones that are going to use easy ingredients. You've got some guidance, that it all really fits where things are right now. But I think it's the best thing you can do right now is that just, you know, put a lot of work into maximizing your health. And the same ways you'd want to be healthy anyway for someday a swimsuit season or just to cut your risk of other health complications, those are the same things that are going to cut your risk from COVID complications. And again, odds are you're going to get it. Now, if you're a lucky one and you end up being after the fact of herd immunity, that's wonderful. I hope that happens. But let's think about this and let's have plans in place for things not working well. Let's be prepared for the contingencies. And the best way you can be prepared is to have your body healthy, have your blood sugar better, you know, have your blood pressure where it should be, have your body mass index a point or so closer towards your target. Any of these things can help you a lot. And if you're already there, this might be prevention because this is a time in which we are just set up to have our risk factors increase, where we can't move in the ways we normally do. We don't have as easy access to food as we would like. So it's a perfect setup for things to go badly if we're not putting energy into it. But if we do put some work into it, we can come through this healthier and we can lower our risk of the complications. And whatever we're doing for ourselves, this is going to rub off on our loved ones. And if we get sick, they might well get sick too. And maybe they've got risk factors more pronounced than ours are. And in that case, you want to be, you want to teach by being a role model. You want to do the things that will help them and make them healthier. So yeah, let's pull together, get your family, get your shelter-in-place mate, whatever the proper term is, and let's plan to do a good reset. And we'll kick it off on April 13th. We'll make this to where it'll work with what you've got. This is not a sales thing. This is free. This is for you. And I'm excited about this being a way that we can be proactive and cut our risk for complications. So that's it. Dr. C with you. Take great care. I'm going to keep on doing what I can to figure this situation out and keep us on top of it. But I don't know, I guess after this perspective, I became a little more optimistic. I guess it was a sense of me personally. I've never really gambled. There's a mindset of feeling like you're going to be the lucky one, right? I don't have that mindset. I'm not a depressive person by nature, but I don't assume that I will be lucky. I assume that if there are things that could go wrong, they could just as well happen to me as someone else. I never assume that I would be otherwise. So statistically, I assume that I could catch this. I assume that it's quite probable before the year is out. And, I want to do what I can. And I've been preparing for Boston. My lungs are in good shape. I mean, the risk factors are not so much there for me, but I think about those that I'm around, and I'm thinking about you. And what can you do right now? How can you lower your risk? And these are the risks. These are things I've already thought about before COVID was ever on the scene. These were the biggest concerns people would ask me about. They say, hey, how do I drop these pounds? How can I get my energy back again? How do I cut my risk for diabetes? How do I not get heart disease? These are the things I heard about all the time. And that's what the reset is all about. So let's do it. Let's do it together, and let's make this a big turning point. All right. See you soon. Bye-bye.